Okay, we've gone live, so just give me a few minutes. Can you all see my screen?
Yes.
Okay. Okay, so hopefully this will work. It usually comes up right away.
Get off and get on my iPad, okay? Thanks.
Assalamu alaikum.
Alaikum salam.
Everyone. Oh, assalamu alaikum.
Alaikum salam.
Assalamu alaikum.
Wa alaikum salam.
Okay, assalamu alaikum. We'll go ahead and get started. I'd like to thank everybody who has joined our session today. And this is just one of our series of candid conversations that we are doing, something Samina and me and Shakila started. Just talking about a variety of topics, engaging the community, and maybe Shakila can give us a little bit more background about that before we get started.
Certainly. Assalamu alaikum. Good afternoon, everyone. The idea of the community conversations is really to engage our community in meaningful topics that are affecting our lives every day. So whether it be the pandemic in this particular case, whether it be Black Lives Matter, whether it be, the current dynamics in terms of engagement. So they all fall under the umbrella of civic engagement. So it's really to help educate and inform our community and to really cover tough topics in a candid conversation and with you in your living rooms and with us wherever we are. And so we really want to thank all of the people that have been participating, and we welcome you to give us thoughts as to what topics, would be meaningful for you and your families, as well as the young adults in your lives, and or if there's anyone in particular that you would like to hear from in regards to contemporary issues and, things that maybe we just don't take enough time to inform ourselves and engage ourselves in. So thank you so much for joining today.
Thank you, Shakila. So today's discussion is really navigating the pandemic, a practical approach. When this all started back in March, we thought that this would be maybe a 6-week thing, an 8-week thing, and we thought then our lives would resume to normal. And now 5-6 months later, we're really realizing that that's really not the case. Dr. Anwar Siddiqui, who's an infectious disease specialist, did a few sessions at the beginning, just really telling us about this virus and really introducing us to this. But now, 5-6 months later, we have to learn how to live with this. And really, that's the focus of today's presentation is from multiple perspectives. Our kids are going to be going back to school, and we, need some tips about that, what we should be considering. Just where do we get tested? Who gets tested? How do we get tested? What does it look like in the hospital? And who should go to the hospital? And what happens if you go to the hospital? Thinking about the immunocompromised patient, what this pandemic, the implications for that. And then wrapping it up with how do we protect our elderly, who are one of the most vulnerable populations. So with that, we'd like to get started. If you have questions, always feel free to enter them in the chat box and we'll try to get to them, inshallah. So I would like to begin with introducing our first speaker. And this is Dr. Asim Shabir. He graduated from Dow Medical College in Karachi, Pakistan. He completed a residency in pediatrics in New York. He is currently with the Community Health Center / WinMed Health Services, and also with Westside Adult and Pediatric Care, which is incidentally, he's also my partner. He's been in Cincinnati for 25 years, married to Sadia with 2 daughters, Nisha and Alicia. So Dr. Shabir will be discussing COVID in the pediatric setting with important measures as schools reopen.
Assalamu alaikum. My name is Asim Shabir. I'm a pediatrician and I'm glad to be a part of this discussion. I'll talk briefly about the opening of schools during the COVID pandemic and how to keep our children safe. Last year around this time, nobody thought that we would be having this discussion. During this pandemic, gradually all other businesses have opened up. This is the first time schools are reopening. As expected, parents have lots of questions and concerns in their mind. The most important question at this time is how our children can go back to school safely. We need to keep in mind that returning to school may not feel like normal for a while. This is an unfortunate reality that cases may increase. So we have to help our school system in minimizing this risk. There's not much known about this virus, but every day we are learning more and more. But we need to keep in mind that nothing is permanent. There is always an end to everything, but it may take some time. Fortunately, children are less likely to have it and it is less severe. We all know that children learn best when they are in school. This is not only good for academics, but also for their mental and physical health. This becomes more important for children with disabilities as they may require speech therapy, occupational therapy, or physical therapy at school. Some children need IEP, which is Individual Education Program. Different schools may have different reopening dates. They may have different policies and procedures in place depending upon the spread of the COVID-19 in the community. It may also depend on the resources available to the schools. So what to expect at schools? Number 1, combination of in-school and virtual classes, going online if cases increase, teachers and other staff members wearing masks for older children, middle and high schoolers, desks 6 feet apart, which means fewer students in the classroom. And in private schools, probably you will see the plexiglass separation between the students. Number 5, more usage of outdoor spaces for extracurricular activities, frequent lunches at desks, frequent cleaning of high-touch surfaces, temperature checks, teachers, not students, moving to the classrooms, assigned seats in school buses, and face coverings. So what is our duty as a parent? We need to analyze the child's need, risk factors, chronic health issues, if any, and home situation. Some of us live in a joint family system. Some of us have elderly grandparents with ongoing health issues who are more vulnerable to this virus. So I would recommend discussing this thing with the pediatrician or the primary care physician. Based on this or her recommendation, discuss with the schools if they can make accommodations. Although this disease is less severe and less common in children, but they can still transmit the virus. Therefore, we need to remind and educate our children on a daily basis. Number one, wear a mask or face cover. It may not be possible for preschool and elementary school children, but at least we can teach them to limit their hand to mouth and hand to nose activities. Frequent hand washing with soap and water for at least 20 seconds. Dropping off and picking up from school if possible. Keeping a safe distance in the hallways and playgrounds. Small group activities. I would highly recommend getting a flu vaccine in this flu season. And it will also be a good idea to check the child's temperature in the morning if it is 100.4 or above, or if he or she is showing signs of an illness. Do not send the child to school and contact the pediatrician to discuss the next course of action. So COVID-19 symptoms are commonly fever and cough are the most common symptoms. Other symptoms include runny nose, sore throat, fatigue, headache, body aches, abdominal pain, diarrhea, and vomiting. Children at high risk are with asthma, chronic lung disease, obesity, congenital heart problems, metabolic disorders, and sickle cell disease, to mention a few. So now the question is, which children need to be tested? If showing, number one, if showing signs and symptoms of COVID and have had close contact within 6 feet with the person with suspected or confirmed COVID-19 infection. Number two, a potential exposure living in an area or traveling to an area considering high risk, with or without symptoms. A known recent exposure to COVID-19 regardless of symptoms. No history of contact, but showing symptoms of COVID-19. Finally, the treatment. There is no specific treatment available in children. It's all supportive, which includes fever reducers, increased fluid intake, and rest. In the end, I would like to mention that respiratory illnesses are very common from fall through winter time in children, and they overlap with COVID-19 symptoms. Having said that, I want to emphasize that not every sneeze, runny nose, or cough means COVID-19. Thank you. I think I can exceed my time.
Thank you, Asim. That was very informative, and I'm sure there's many more questions. Please send them into the chat box, or we'll have a time at the end also. But yeah, with schools opening, I think we're probably having a lot more questions arise over the next few weeks as well. So thank you again. Next, I would like to introduce our next speaker. This is Dr. Hussam Hamed, and he studied medicine in Damascus University, Syria, trained in family medicine at Bethesda North Hospital in Cincinnati. And I'll add a little personal tidbit. My first night as an intern at the hospital, he was my senior, and I was terrified. I had no idea what I would be doing. And alhamdulillah, he was a great teacher, so I have a lot of respect for him. He has practiced in primary care, urgent care, hospital, and nursing home rehab. He's affiliated with urgent care of Fairfield, Coleraine, Hamilton. Dr. Hamed has been in Cincinnati for 22 years. He's married to Dr. Maram Kabaz with 4 kids, Hajar, Noor, Sham, and Ibrahim. He'll be discussing the diagnosis of COVID with a particular focus on when, how, where to be tested. Thank you, Dr. Hamed.
Thank you, Samina. It's good to talk about residency, even though it's been so long. Jazakallah khair. Jazakumullah khair at ICGC for taking leadership of this. Mashallah, Dr. Asim has covered a lot of what I was going to talk about, which is like who needs to be tested. So I'm going to start by reiterating that this is a new virus. It's a novel virus. So we are still learning every day about the virus, the infection, the testing, and treatment if needed. We, as always, say prevention is before treatment. So I would recommend highly that everybody takes every possible precaution not to get infected or not to get exposed, and then if exposed or infected, to be tested. So things to do at home to try to minimize risk of infection is to social distance from others by staying about 6 feet apart. And if you are in a gathering for whatever reason, stay in the smallest possible gathering. Wear a mask if you are to be in close contact with people. Frequent hand washing with soap and water for about 20 seconds. Continuous hand washing. And if you don't have soap, then you could use hand sanitizer with 60% alcohol concentration in it. As Dr. Asif mentioned earlier, people that need to be tested are the people that are symptomatic. And even though the spectrum of symptoms is wide, it is difficult to say who needs to be tested, but anybody with symptoms that is living with somebody with weaker immune system for diabetes, rheumatoid arthritis, heart disease, or cancer, or just with elderly people need to be tested. Now, the symptoms can be very subtle. People are coming to the urgent care to be tested when they have lost the smell or the taste of food, and they are testing positive. So we at the urgent care centers are testing for COVID-19 in 2 ways, and soon we're adding a 3rd way. We do have the COVID-19 PCR, which is the real-time PCR, which detects the live material of the virus, or the RNA, the nucleic acid. This test is pretty accurate, over 90% accurate, close to 100%. And it tests the virus shortly after exposure, and it can be positive for up to 2 or 3 weeks after exposure. The test is best known as the nasal swab. It's nasopharyngeal swab going through the nose to the back of the throat to collect the sample. The results are ranging from 1 day up to a week. At our urgent care centers, we are getting the results now in about 24 to 48 hours, sometimes shorter than that. The other test that is available is the antibody testing, and this is to measure or to detect the proteins the body makes to fight the infection. And those are 2 types, IgM and IgG. The first one starts being present or being detectable in the blood in about 10 days after the exposure. The other one is present after 20 days of exposure, and if found positive, it may mean that you have had an infection and you are fighting it, or you did fight the infection already. So the health department keeps changing the recommendations for when and who and where to get tested, but testing now is widely available at the health departments, hospitals, urgent care centers, and some doctors' offices. However, a lot of hospital systems have restricted testing to their own patients. You mentioned we're adding one more test, which is the antigen testing, which will test for the capsule, which is the coat around the live material of the virus. This is also a nasopharyngeal swab. It will be done in the office with results in 15 minutes. The same thing as the antibody, which is a finger stick blood test, molecular blood sugar. It results in about 15 minutes to tell you if you've had the infection before. I think I covered almost everything. So if you have any questions, I'm available. I'll be here to the end of the presentation.
Thank you, Dr. Hamad. Yes, it's surprising, even though they say testing is so widely available, sometimes when you need it, you're running around frantically trying to figure out where to send your patients to. And you're right, the hospitals have changed to only doing their own patients now. So that's a bit of a thing.
It is correct. So I would advise for everybody before walking into an office to be tested to call ahead of time for 2 reasons. number one, you need to know their protocols for testing. Do they allow walk-in? Is it drive-through? Is it testing at the door? Number two, you want to know what testing they have and what is the turnaround results. I have had a lot of people from the community contacting me because they need to travel out of the country, and it is now required by airports and airlines for testing to be obtained and resulted before they board the airline, before they board the plane. So be sure that you have enough time to be tested, follow the instructions. Like I said, different testing centers have different results. Some of them are taken up to a week, others are resulted in 1 to 2 business days. So make sure you call ahead of time. In our urgent cares, we request that you call when you are at the door. Somebody will walk out and escort you to a testing room where you would be swabbed, and also will walk you back out to the parking lot to go back to your car and leave. So call ahead of time and follow the instructions.
Yeah, yes, and I can attest to have sent patients your way, and we do appreciate the quick turnaround. Now, for those flights, that's just for international, right? Domestic is not requiring that yet, are they?
Correct. Correct. It is for international. That's why I said outside the country. Yes, it is for international flights.
Okay, good. Okay, thank you, and please
One
stick
of,
around because there's
just
more questions. Shakila, go ahead.
Sure.
real quick, Dr. Hussam, one thing that we need to also keep in mind, I think it's great that you'll be adding the third test, which I think we're at the stage of the pandemic where I think that would be very helpful. The one thing we need to keep in mind is within our community and the population in general, people are at different levels of means and coverage. So from what I understand, some of the pharmacies such as CVS are offering the test, which is self-administered after an appointment without a charge. Are you aware of any other options for people who might be in such a situation without healthcare coverage?
I know the health departments would do the same. Some hospital systems will do the same also. Now, the testing itself, the government would cover the testing for everybody. So if you don't have health insurance, the government will take up the charge of the test. It's the administrative cost of processing, like registering, filling the paperwork, and collecting the sample that can differ from one office to other. Some of them are charging, over $100. Others are charging minimal fee for the collection. But the test itself is billable to insurance. It's covered on all insurance companies. I just heard lately that Cigna is not allowing a test without actual symptoms. So it's a ongoing changing process now. Like I said, testing is free. If you don't have insurance, to test will be free. The processing fee, if anything, it would be variable from one company to the other. So the health department does it for free. They don't charge for the collection and what have you. It's news to me that CVS is doing it. That's great. Thank you for sharing that with the community. That is quite helpful. We do collect the test. We do charge a processing fee, but we will be happy to work with the masjid to make it as little as possible, to make it affordable and not have to wait in line or be at risk of not collecting the right sample at home. If you're swapping your own self, you're not a nurse, so I don't know how you would swap yourself properly to get a good sample, to get a good negative or positive test. And the test is as good as the person doing it, unfortunately.
So just a very quick follow-up in regards to that last comment is that, I mean, we saw the scenario with our Ohio governor where he got a positive and then 2 negatives. What would you say your experience has been? And are there any statistics in regards to the reliability of the tests that, at least the first 2 that you've mentioned?
So the PCR or RT-PCR, real-time PCR testing, the nasal swab, is very highly sensitive and specific, meaning if it is negative, it means it's negative. If it is positive, that means it's positive. Having said that, I go back to the statement, the test is as good as the person doing it. So to get a proper sample, you really need to push the swab through the nose all the way to the back of the throat to collect a good sample. So if somebody just swabs the tip, into the nose and pulls it out and you get a negative test, that can be a very, poor sample and it's false negative. You did not collect the material for the test itself. But if collected properly, it's very sensitive. It's almost 100%. Now, the antibody is also above 90%. It's not 100%, but it's above 90%. It does have some cross-reactivity. So COVID or coronavirus has been around for years. It's not new. It's not new. So coronavirus gives you cold-like symptoms. So runny nose, sniffles, what have you. Coronavirus has been there. And MERS was another version of coronavirus. So a positive antibody testing is not a definitive diagnosis. Then a PCR or more definitive testing would be recommended if you have an antibody positive test and you need to follow up on that. If you think you are ill or you need to donate antibodies, then a lab done antibody test, it's almost 100% accurate, and that would be done as a next step.
Thank you. Let's see here. So next I would ask Shakila to introduce our next speaker. Thank you, Dr.
You're welcome.
Oh, certainly, Samina. Just it's a pleasure to introduce Dr. Shala Malik. Shala completed medical school at Dow Medical School in Pakistan. She trained in internal medicine at Good Samaritan Hospital and completed a fellowship in pulmonary and critical care at the University of Cincinnati. She is currently with TriHealth Pulmonary and Critical Care. Dr. Malik has lived in Cincinnati for almost 30 years. She has two wonderful sons, Faraz and Kashif, and a lovely daughter-in-law, Arij, as well as parents and siblings in Cincinnati. Dr. Malik will review the COVID patient in the hospital setting, particularly the fact that she deals quite a lot with ICU patients. Shala, thank you.
Shakila and Samina, Jazakallah khair for such a nice introduction. And also thank you for ICGC for allowing me for this panel discussion. So I'm going to talk about, I was assigned to talk about COVID-19 and intensive care unit. And intensive care unit is a specialized unit in the hospital and that cater to patients who are severely or critically ill and that need a constant around-the-clock supervision from a group of trained people, including the nurses, the respiratory therapists, and the physicians. And these trained staff also know how to take care of the life support equipments and specialized medicines or infusions that usually be needed in the intensive care unit. When the surge and the pandemic started in March, thank you, Samina, for next slide. One of the goal was the streamlining of workflow from diagnosis to identification of the patients, testing, isolation was initially a big job because most of the intensive care rooms were not negative pressure isolation, which means patients who were COVID positive need to be isolated in a negative pressure room and the management. So these were all the challenges we faced initially, including the hospital administrators, the staff, the physicians. And just to this slide, which I have for the critical care, to get a concept of how many beds we have in, in different countries. This is a slide from a few years ago. In United States, there are 34.7, almost 35 ICU beds for 100,000 inhabitants in selected so in our country. And you can see the rest of the countries are also well-developed countries. So we are not talking about a lot of ICU beds here. Even if you increase the ICU beds, it's only to get the staff as well as the equipment and the breathing machine. Those were always a challenge. And I do think that in New York, when we saw the higher mortality initially, was because of the less staffing and not just creating a bed as compared to the mortality in the rest of the other states. Can we go to next slides? I'm not going to talk about the symptoms since the other two physicians have covered it, but after the incubation period and after the initial symptoms, not everyone needs to be admitted. They do come to the ER, get tested, and any viral illnesses, some of the symptoms are self-limiting and like achiness, cough, fever. It goes away by resting and Tylenol. But after a week or 10 days, sometimes 40% of the patients may develop what we call shortness of breath and worsening cough. And out of those 40%, 5 to 15% may need to come to the intensive care unit or need higher level of support or care. And most of them, can we go to next slide? Most of them are usually 100% have a respiratory or lung involvement, and the symptoms are cough, low oxygen level, and we will talk about that in a second. The one thing, anyone who appears ill or low blood pressure or low oxygen level are usually admitted to the hospital. Initially, they are admitted to a different, what we call COVID unit or different specialized unit in the floor where they are monitored very closely, and strict infection control procedures are needed all the time. Clinicians, they do partner with the patients and they discuss with them about the advanced directives. Just because when you are admitted to the hospital with this COVID pneumonia, there is a chance that the disease may progress and you may not be able to make your own decisions. So they want to know their surrogate medical decision makers and establishing appropriate care of goal of care. Because we had patients from 50 years old to 90-year-old, and having a 90-year-old with a discussion with them and the family, and I guess we will have discussion about that also later on. Is very important. Oxygen should be supplemented in patients whose oxygen level is very low, and deciding whether to move them to the intensive care unit and to provide an artificial mode of supporting their breathing, which we call a ventilator, is a critical aspect of caring for all these seriously ill patients. And 5% of the patients, besides needing respirator or ventilator, they also need a dialysis when the kidneys fail in the intensive care unit. Samina, can we go to next? I think there was one slide which is missed, but most of the symptoms, again, in the ICU, that's okay. I don't know where it is, but it's the lung related. And the lung, it can be mild, simple pneumonia. So this is an X-ray. I just wanted to show the normal X-ray that this is the right lung and left lung, and it should look black. And the next slide. But when you see the blackness replaced by whiteness, that's the pneumonia. And it can be mild case where you're needing oxygen at a lower level versus what we call acute respiratory distress syndrome, where it is hard to, gas exchange does not happen very well in the lungs, and the oxygen is not pumped into the rest of the body very well. And this is where you need a respirator to help you to breathe. So different, I just have a slide for different oxygen. You know, we can provide simple oxygen from the urgent care, as we described, from just a simple cannula, which can provide from 2 to 5 liters, from a mask, which goes on your face and the concentration of the oxygen goes up, and versus also a CPAP machine or a BiPAP machine, which pushes the air with a force to the lung to help with the gas exchange in the lungs. And this is a picture, I don't know if everybody can see it, is a picture of a respirator or cartoon of a respirator. No, little bit, yeah, where the tube actually goes through your mouth provides the air with oxygen and helps to get rid of the carbon dioxide. And once you are on the respirator, sometimes we have to sedate you with a different kind of drugs because it's uncomfortable to have a tube in your mouth. And then we have to have a tube in your nose to provide nutrition and medicines. So this is the severe case of COVID-19 pneumonia, where you may have heard and seen the picture in the news in the intensive care. But let's go to another picture. So before we end up on a respirator, we try different modalities to improve the oxygenation. And one is very well known, and it's not only for COVID. We have done it for other kind of pneumonias like influenza and other acute lung injury. It's called prone position. Basically, most of the patients are laying on their back, but this is we put the patient on their tummy, on their belly. It does need a whole teamwork. It's not that easy when you're hooked up to too many machines. It does need a whole ICU team to turn the patient. And once we turn the patient to prone position, we leave them there at this position for 16 to 18 hours continuously. And that does help to improve the oxygen saturation and improvement in the numbers. So patients who are on the floor and before they transfer to the ICU, I do recommend them to sleep on their belly for 6 to 8 hours, then turn on the supine, like on their back, up in the chair. So changing the position, the lung does changes the, improves the gas exchange. So just to, if somebody is at home and, have slight pneumonia, they can start doing this. Doesn't have to wait till they come to the hospital. So the next slide. As it was mentioned before, little is known about the treatment at this time. Nothing is proven. Initially, we all were doing Plaquenil and Zithromax, but those we are not doing it anymore. The FDA has granted emergency use authorization of remdesivir. There's a criteria if you're in the hospital or you're needing oxygen. We do go ahead and provide that. Right now, there's enough medicine, at least in Cincinnati hospitals. So there was a shortage in March and April. We are using a steroid, which reduces the 28 days mortality in patients who are needing oxygen in the hospital. We are using a convalescent plasma, which, as was mentioned, if you develop your natural antibodies, people who have COVID-19 are donating their plasma. So we are using those for patients who are admitted to the hospital. There are other drugs in research right now. And the outcome depends upon at what time you can come to the hospital, your underlying age, comorbidities, and obviously, if you just limited to the lung problem or you develop multi-system organ failure, some of the patients can develop shock, which means that low blood pressure and increased heart rate. It can involve heart problem, liver, and kidneys. Patients can also have acute heart attack. They can have rhythm problem. So it is a close monitoring of all your body labs, vital signs, and different positioning, and providing adequate oxygenation. So more than medicine, is more taking care of their organs and get them through this acute event. The only thing is it does take approximately, depending upon patients, from somewhere from 4 to 8 weeks in the ICU to start having a healing process. But I have patients who have left the hospital, and we have seen good recovery also. That's all I have for right now.
Thank you, Shella. So if I heard you correctly, if you
Thank
have
you, Dr. Shella.
Go ahead. Go ahead, Shakila. I was just going to say, if I heard you correctly, did you say that if you have COVID at home and you're having breathing problems?
Yeah, we seem to, I don't.
Can you hear me?
Can you all hear me?
I can hear you, Samina. Yeah.
I don't know if Shakila can hear me. I was just saying, if you have COVID at home and you have a breathing problem, did I hear you correctly to say to go into the prone position?
Yes, definitely. Meaning from the ER, if you do have pneumonia, meaning like a shadow in the chest X-ray mild, we encourage them the prone for 2 or 3 hours. They don't have to be prone for 16 hours like we do in ICU, but sleep on a belly, sleep on a back, sleep on a belly. It improves the what we call VQ mismatch and improve the oxygenation. Yes. We recommend that everybody on the floor, especially if they're admitted, but in the home, they may not be that sick then, but it's not a bad habit to encourage that.
I know we're going to take questions at the end, but one came in specific to what you said. Can you elaborate on the time of improvement after you receive plasma?
Plasma and remdesivir, both are not the treatment. It has only shown to decrease the duration of ICU length of stay. So if we wouldn't have given plasma, which we didn't give it in March and April, patients still recover. So we have seen only 2 or 3 days less shortened length of stay in the ICU. So you can start seeing oxygenation, the liters flow of oxygen getting better, their symptoms starts getting better. But it's not like a switch on and switch off kind of thing. It's just that you may leave hospital 3 days early, which is I think a good number. But it's not expected to like next day you're completely fine. And actually plasma also, we are very careful because it's like giving any blood products can have some side effects. Is a volume overload, can have a fever, can have a reaction to that. So if you're very sick, sometimes we haven't given plasma because if they're already volume overloaded, or we have to give a lot of Lasix or like diuretics in between. So, but that's why we recommend plasma and remdesivir to be given on the patients who are before coming to the ICU, who are early on admitted to the floor. So those we do get consulted on the patients who are admitted to the ER or floor or COVID unit. That's where we try to give plasma and remdesivir. If you're already on a respirator, it's usually too late. So we just do supportive care in the ICU.
Okay, that makes sense. Thank you.
Mm-hmm.
I'm sure there will be more questions coming in. We'll move on to our next speaker. Shakila, are you able to, are you there?
Yes, can you hear me, Samina?
Yes, we're good.
So we're really very pleased to have Fumi Adewumi. She's a certified nurse practitioner, very qualified, who originally immigrated from Nigeria and completed her nursing education at Ohio Northern and South University in Georgia. She has been practicing nursing for over 30 years and currently working as a nurse practitioner with UC Hematology Oncology in Westchester. She is married to Dr. Wahid Adewumi, and mashallah, they have 4 children, Mariam, Aminat, and twin boys, Kamal and Kazim. They've lived in Cincinnati, Ohio for 12 years. She will be discussing the implications of COVID in the immunocompromised patient, starting with the definition and how this is such an important area. So thank you, Fumi, for being with us today.
Thank you so much for the introduction. Assalamu alaikum. My name is Fumi Adewumi. I'm a nurse practitioner, and I know it's going to be a little bit challenging to follow all these physicians, but I'll try my best. My topic today is going to be the immunocompromised patient related to COVID-19. What does it mean to be immunocompromised? Immunocompromised means having a weakened immune system. Our immune system is like a strong army with the mission of protecting us from infections, viruses, and bacteria, and diseases. People who are immunocompromised have a reduced ability to fight diseases and infections. The weakened immune system can be either permanent or temporary, depending on the cause. Next slide. What conditions lead to a weakened immune system? Next slide. Number one, we have the chronic diseases. We have the cancer, HIV and AIDS, diabetics, lupus, malnutrition, rheumatoid arthritis, and some genetic disorders. Chronic diseases such as those mentioned above in one way or the other destroy immune cells, leaving the body more prone to infection, such as COVID-19. We have the medical treatment also can weaken the immune system, such as chemotherapy for cancer patients. Chemotherapy kills both the bad and the good cells, which weaken the immune system. Corticosteroids and biologics, which are used to suppress hyperactive immune system in diseases such as lupus and rheumatoid arthritis, can make it difficult for one to fight infections such as COVID-19. Next slide. Old age is another condition. As people grow older, they can develop chronic diseases, which will impact their immune system and ability to fight infections, such as COVID-19. Organ or bone marrow transplant. Transplant patients often take anti-rejection medications called the immunosuppressants, which affect their ability to fight off infections such as COVID-19. Smoking is another condition. Smoking tobacco damages one's respiratory tract. COVID-19 being primarily a respiratory illness can be more severe among smokers. And how to protect yourself from COVID-19 if you are immunocompromised. We've heard about it from our doctors, but I'm going to say more about it. The most important thing is to avoid exposure and infection. Follow CDC recommendations, social distancing, stay home and avoid other people. Remain 6 feet away from others. Go out only when necessary. Wash hands regularly with soap and water for at least 20 seconds. We've heard about that many times. We use hand sanitizer, which at least 60% of alcohol when hand washing is not possible. Wear your face mask when around people and demand that they wear one as well. And if you are sick, call your physician and seek help. This will be the end of my presentation. Assalamu alaikum.
So for me, I think we're at, again, a stage of the pandemic where I think there's hardly any of us that doesn't have someone that's been affected. So You know, we have a loved one who had chemotherapy and very unfortunately contracted COVID because it got into the house. The antibody test showed there were 0 antibodies in this patient. So, you know, I think maybe if you could just talk a second as to the implications of that and the lack of the ability of such patients to be able to fight the disease in any way whatsoever. I don't think people realize the impact that can be on these patients versus the rest of us who may have a hard time as it is.
Yes. With our cancer patients, when they are on chemo, the chemotherapy already weakened their immune system. And cancer itself is very difficult for them to fight infection because unable to produce the antibody to fight infections. So that's why most of the time we tell our patients to please stay home because the immune system is already weakened, and try as much as possible to expose yourself. Usually, we can use when they come in, we tell them only come out when you have to come out for your treatment. Stay home most of the time and make sure you do not expose yourself and prevent infection. Yes, it's going to be difficult to fight the COVID-19 when you already have the weakened immune system because you cannot produce the antibody to fight.
Thank you.
You're welcome.
Thank you. And I'm sure, as Samina said, there will be other questions that our audience participants may have.
Yes.
If okay, I will continue to introducing our last speaker. It's Dr. Sabah Ansari. Dr. Ansari graduated from the University of Minnesota Medical School. She trained in internal medicine and geriatrics at the University of Cincinnati. She is currently with the Giro's Medical Group and has lived in Cincinnati for 20 years with her husband, Dr. Junaid Malik, and their 3 kids, Isra, Khalid, and Amina. Dr. Ansari will be discussing COVID in the elderly and measures to keep them safe. As Dr. Shala and Dr. Asim mentioned, that many of us have parents or grandparents that are in the region. They may be living with us, or we need to help take care of them. And so, Dr. Sabah, I'll turn it over to you if you could take it from here.
Assalamu alaikum, everybody. Shakila and Samina, thank you so much for inviting me to this esteemed panel. I think Shakila just pointed out an important concept that's going to sort of lead me into my presentation here. In general, the risk of COVID is determined by the more people you interact with and longer the interaction is. And the reason I want to emphasize this is that, as Dr. Hossein had also pointed out, prevention is going to be sort of the keystone since we don't have a treatment. And I do understand a lot of our elderly in the community live in multi-generation households. So I think it is very important that there's a frank discussion in the household about what kind of risks other members in the household that are not elderly are going to be willing to take, because that risk also carries on to exposing some of the elderly that live in that household. As some of our speakers have pointed out, once COVID enters a household, it's pretty much guaranteed that it's going to spread pretty much within all members of the household. So I think this is very important to emphasize, especially in light of what Dr. Shabir just pointed out, the schools opening in the midst of a pandemic. The other thing is that I do want to emphasize is that this is a new disease for all of us. And it's been a learning curve for pretty much all of us, including doctors and nurses and other medical practitioners. In addition to this, you as a community have probably been quite confused by fluctuating recommendations coming from the CDC, the World Health Organization, from some of our government officials. So really, it's been overall sort of a confusing series of different things. I think as far as masks, that issue is pretty much settled. I'm glad it's a little behind us and everybody's kind of pretty much, accepted the fact that everybody needs to wear a mask, especially indoors. By indoors, I mean when they're outside, but going into stores and so on, restaurants, masking is going to be very important. Social distancing, that's also something that has been settled. Although I do want to point out, we keep saying 6 feet, but that's sort of an average. This virus can be transmitted way beyond 6 feet. So that's the minimum that is recommended to maintain in a practical sense. But we do have to know that if you're going to be indoors, the risk of you contracting this virus is going to be higher, whether you're 12 feet away or whatever, especially if you're in an environment where there's other people, such as a restaurant or something of that sort. The other thing that I wanted to point out is we emphasized hand washing. I think Dr. Shabir did and a few others did as well. I want to bring up this issue of sanitizers. And if you're going to have them at home, whether it's for the elderly or for the household, you want to make sure they're at least over 60 to 70% alcohol content. I was at Myers the other day and I saw anything from say 42% to 90%. So if you're going to use them, you want them to be effective. So just you want to make sure that if you're going to use sanitizers, and using sanitizers, I don't think is a replacement for hand washing, but if you don't have access to water or hand washing or a sink or something, that's probably what you can easily carry with you. Having said that, these are just some of the general things I wanted to start off with. One of the things that I wanted to kind of elaborate on is my experience over the last 3 months. I've actually been taking care of patients in what is called a COVID recovery unit. Now, this is different from what Dr. Malik pointed out. This is outside the hospital and basically is in a nursing facility, but a dedicated unit for elderly folks that live out in the community but have been hospitalized for various reasons. Now, I will tell you, and this is a little bit of an unusual observation, but I will put it out anyways. It may be anecdotal, but I do want folks to know about it, is that I've taken care of probably a little over 100 patients since June that have come into the COVID recovery unit. 30%, let me just start off by saying that the average age in that unit that I've been taking care of is about 82. So anywhere in the range of 50-year-olds to my oldest patient who was 99. 30% of the patients that I have seen in this unit have actually been completely asymptomatic, diagnosed with COVID, but asymptomatic. You might ask, why are they there in the COVID unit? Well, these folks ended up in the hospital for unrelated reasons, unrelated COVID reasons, such as a hip fracture or had a heart attack or some other reason, and they were tested, as they routinely do in hospitals nowadays, for COVID and were positive. So I want to emphasize 30% of elderly also can be asymptomatic. 30% have actually had a pretty severe course of disease. And these are the patients that Dr. Malik pointed out that have been in the intensive care unit needing a lot of support, ventilation, and so on. And 30% of that group that I'm taking care of has had variable disease. They've been sick enough to be in the hospital, but not in the intensive care unit, needed a couple of weeks, and then came to the COVID recovery unit to get stronger before they returned home. And the 10% that I'm missing there is a mixed bag. They've had symptoms, but have been okay. So I really don't know where to place them. Having said that, a few other observations that I've kind of noticed while taking care of these folks is that how they do has a lot to depend on what we call their functional level. So in general, if you have two 85-year-olds, one is pretty active and the other isn't, the one who is active is going to do much better when they acquire or get COVID, irrespective of what their comorbid or other medical conditions are. So that's important to keep in mind. So if you can, depending on where you are or what your problems are, it is important to keep in mind the more physically active you are, the higher your functional level is, the better you're going to do. The other thing that I wanted to point out is, yes, chronic medical conditions do make a difference in how you recover from this disease. And the two medical conditions that I've seen that seem to make a big impact on your recovery, at least in the population that I serve, are diabetes, obesity, and heart disease. So the reason I'm also emphasizing this is we have a lot of elderly in this community that are afflicted with those conditions. So it is important for you, if you are dealing with those diseases, to make sure those are under control. So for instance, if you have diabetes, you want to make sure your sugars are controlled. If you have other medical problems, such as hypertension, that's also a risk factor. You want to make sure your blood pressure is controlled. And you want to take care of that right now. You don't want to do that when you start having problems. So what I would emphasize is that we're in August, we're going to be entering fall soon. And of course, you're going to see a multitude of respiratory infections. Aside from COVID, you're going to see probably the common cold, flu. I think it would be good for a lot of our elderly folks who have medical problems to sort of connect up with their healthcare practitioners, be it your doctor or your nurse practitioner, to just kind of get a sense of how they are doing in terms of how stable these diseases are. Do they need a change of their medications? And there are multiple ways of doing that. You can do it by telehealth, which has become quite popular now if you don't feel comfortable walking into a clinic. But I will tell you that the chance of you acquiring COVID from a health institution like a clinic or something like that is not as big as people think it is. I think they are taking multiple precautions, sanitizing, everybody's wearing a mask. So it's a risk benefit thing. But I think if you feel comfortable with it, it is good to pay your doctor a visit and make sure you go over all your problems so they're under control. The other thing I want to emphasize, and this is going to be coming up pretty soon in the next month or so, is vaccinations. The flu vaccine is going to be out in the next couple of months, and I would encourage all of you to be first in line to get it. The reason I'm not trying to imply that flu vaccine is going to help you prevent COVID by any means. However, you don't want a double whammy, because just because we're in the midst of a COVID pandemic doesn't mean that the flu virus has disappeared. So you certainly don't want that. So anything you can do to maintain your immune system, maintain your health, do it. So be the first in line to get your vaccinations up to date, your flu vaccine, your pneumonia vaccine. I would go as far as to say, consider taking a shingles vaccine, because if you're compromised and you get a bad illness and you have an outburst of shingles, that's not pleasant either. So whatever is recommended in terms of vaccinations for the elderly age group, which is usually some of these vaccines I just talked about, go ahead and get them. And this is the time to do that. The other thing that I want to bring up, and this may seem common sense to a lot of you, but I do want to emphasize this is because I've heard it multiple times. I've had people that are fearful of going to the hospital, even though they're very sick and they need to be seen in a hospital. Your risk of dying from a heart attack or a stroke, or God forbid you fell and you broke your hip, is going to be much, much, much higher than acquiring COVID from the hospital. So if you need to be taken care of for an acute condition and you need to be in a hospital, you simply need to be in the hospital. Because if you don't take those, if you don't take control of those ailments, such as a heart attack or a stroke or whatever it is that needs you to be in the hospital, there's not going to be COVID anymore because you'll be gone before that. Okay. The one other thing that I think we all forget to point out, and nobody really puts it in the category of comorbid conditions, but I do want to emphasize, is that in my mind, at least in what I have seen so far with my patients, depression, anxiety, physical isolation has been a big, big part of how they recover from things. And I'm actually going to venture on and actually put it as a risk factor, because if you're depressed, if you're anxious, those things are not under control, your chances of recovering, if you do get COVID, or for that matter, any respiratory illness or any serious illness, is really diminished. I don't have an answer for you. I think we as a community have to kind of discuss that in households and, like I said, as a community. And I think it would be great for Shakila and Samina to kind of keep that in mind and invite, panel involving psychiatrists and psychologists to see how we can actually address that, especially in the elderly. One other important thing that I do want to point out is that we've talked about some of the symptoms, the coughs and colds and so on, but in the elderly, you can have a lot of atypical symptoms. In other words, you may not mount that temperature that we talk about. One of the reasons may be is that a lot of our elderly take around the clock Tylenol or Advil or whatnot, and that may mask or suppress a fever. So you may not necessarily display a temperature. Same thing with respiratory symptoms, even though majority of our COVID patients do manifest some degree of respiratory symptoms. Sometimes the elderly, especially those of advanced age over the age of 85 or 90, may just present with just malaise and confusion and not eating, things like that. So I think it is very, it's important to be aware that the symptoms in the elderly can be quite atypical. Now, one of the things, and this is something that I use on my patients that have COVID but are not sick enough to be hospitalized, is to monitor them with what is called a pulse ox or an oximeter. I don't know if you can see this. This is a little device that I would actually encourage households that have elderly populations to invest into. It costs probably somewhere in the range of $20 to $30 on Amazon or one of the health stores. But I think it's worthwhile to do that because one of the signs that you need a higher level of care or need to be evaluated in a hospital is when your saturations, that I think Dr. Malek also pointed out, start dropping. So I'll try to see, I don't know if you're going to be able to see this, but when I turn this on, for most normal people, your saturation is going to be close to 100. Even the elderly, you're going to probably have that number somewhere between 97 and 100. That's your baseline. When you start having respiratory symptoms, whether it's due to COVID or flu or any other respiratory ailment, and if you see that number gradually dropping, that's an antenna to be raised, where you might want to think about getting evaluated, whether you want to notify your doctor, or if you're not feeling too good, even probably show up at the hospital. So I don't know if you can see it, it says 99 here, but if I was having a lot of respiratory symptoms, not feeling well, maybe had some exposure to COVID, or maybe in my household there's somebody who was just diagnosed with COVID, and that number starts falling to say 95, 93, 92, it is sort of a sign that you need to be evaluated, most likely in the hospital. Last but not the least, one of the things that I wanted to point out is that it is important to develop a care plan. And what do I mean by that? That means a piece of paper where you've typed up all your medical problems, or, I know a lot of our elderly are pretty tech savvy as well. So to have a place, whether it's on your phone or a written set of a summary, basically, of your medical problems, what medicines you take, who your emergency contacts are, who your healthcare providers are, and what your wishes are, basically, what we call advanced directives, sort of written out. And that should be carried with you at all times. If you're leaving your home, it can be in your wallet. And I would also encourage you to give it to a family member that is close to you, or maybe all your family members, just so they have a copy of that. Because one of the things that we're dealing with in nursing homes, in hospitals, and a lot of our doctors will point to this, is that there's visitation is being restricted. In other words, there may be situations where only the patient is allowed to be in the hospital, even be in the ER. Maybe it's the only person that's out there is the patient, not a family member, not somebody who can provide a history. And a lot of times, if somebody is sick enough, especially if you're elderly, you may not be able to provide all that information. You may be confused. You may be too sick to talk to anybody. So at least you have that information on you where the provider has access to it and can at least start off there. We talk about technology. I know, we have electronic medical records, but you'll be surprised as to how many times our electronic medical records don't talk to each other. So a clinic electronic medical record may not talk to the one in the hospital. So I think the old-fashioned way of just having a care plan with you at all times in your wallet, easily accessible, is a good idea. Last but not the least, and I also wanted to say this because I am the last speaker on this panel, is belief in Allah subhanahu wa ta'ala, the power of du'as, the power of grit, the power of motivation, and a strong will to beat this and get better. It goes a long way. No matter how good a medication or a doctor is, nobody can kind of make it happen unless you have that will and desire to get better. So inshallah, that is all I have to say. and appreciate any questions.
Dr. Saba, thank you so much. I know there's maybe a couple of other questions, but I just, the last point you made is so vital for us to keep faith, keep a positive attitude, take good care of ourselves. The other point that you made that I think is very important, and we as a community need to realize that there are many who are alone, whether it be the elderly, whether it be single moms, whether it be a family who has no other relatives. So please just every day check on a person, just shoot them a text. And it could be obviously somebody in the community, it could be somebody else that and sometimes you don't realize how much they're struggling in this period of isolation. So thank you for bringing that up. And most certainly Samina and I will with the wisdom of many in our community, come back to that topic. So jazakallah khair. Samina?
Yes. So thank you, Saba. I had actually put this at the end, but since you brought it up earlier when this pandemic first came out, Imam Musa had actually reminded all of us to recite this dua, after every Maghrib and Fajr, Bismillah alladhi la yadurru ma ismihi shay'un fil ardi wa la fis sama'i wa huwa as-sami'ul alim. It's from our hadith, a dua of protection amongst everything else that was said. So I appreciate you reminding us of that. We do have a lot of questions that have come in, so I will start presenting them. But if in case people sign off before the questions are done, I'd really like to thank all of our panelists for doing this, taking out time out of your busy weekend, and just presenting this is really a benefit to the community, and we truly appreciate it. So that being said, I'm going to first turn it over to Dr. Shabir, and it's a question for him. If you can go ahead and unmute yourself. It says, why did you pick 100.4? What about 100.2 or 100.3? What is the thought process?
There is no magic number, but in general, the temperature varies in a normal person from 97 to 100.2 to 100.3. In general, if you are fighting off an illness or if you are contracting an illness, usually it goes like from 100.4 or above. That's why I use that number.
Okay. And then I think you had wanted to add something about testing. Did you?
Yeah, actually, I would like to thank first Dr. Hussam for detailed, availability of the testing and the information. Since I work for community health centers, I just want to let you know, especially for people who don't have any insurance or who are underinsured, that our community health centers, they are offering tests regardless of the insurance. And some of them are for walk-ins also. And it will be a good idea to call the community health centers if they want to be tested for an appointment.
Thank you. Another question that came up was, what is the age requirement for shingles vaccine? So I don't know who wants to take that one. I know all of you know. Shayla, go ahead. Or Asim, or anyway.
Actually, I don't primary care, so I don't.
Okay.
I think it says about 55, but somebody can correct me. Whoever does the more primary care, or but I think it's about 55, isn't it? Or Samina, it's probably.
That's about right, but it's also pending insurance coverage.
Okay,
so,
yeah, I know. That's yeah.
So Saba, you want to add anything about that since you mentioned getting the shingles
I
vaccine?
think a lot of times I get this asked a lot, that what do you mean by the elderly? So the way I define elderly is what your body is like. So you could be the elderly in your 30s and 40s and 50s. The reason I say that is I think those kind of vaccinations should also be based on your comorbid conditions.
Yeah.
So for instance, if you're a brittle diabetic, or you have multiple other medical conditions, you might consider getting it earlier, in your early 50s or whatever. But in general, I think, Shaila is probably right. They advocated for folks over 55. And I surely understand that, the insurance issues are there, but sometimes you just kind of have to weigh the pros and cons of just going ahead and just getting that, because after all, we're talking about your health.
So another question that came in was, and I'll ask Funmi to address this one. You mentioned the immunocompromised conditions. Would obesity also be considered one? And just, Funmi, you have to unmute yourself. One more time, I accidentally. Try again. Okay, now, and there you go.
Okay. Yes, obesity is one of the conditions that they will tell you if you are obese, you're at high risk of COVID-19. Or overweight, have the BMI to follow. And when one is obese, it affects all the organs. And so we are at risk of COVID-19.
Okay. And then another question for Dr. I guess anyone can answer this, but I'll send it to Dr. Hamad. If I get diagnosed with COVID and I don't have anything more than mild symptoms, how long is my quarantine and when can I go back to work and be around my family?
So once you have a positive test, you're supposed to quarantine yourself, ideally for 10 days from the beginning of symptoms. So after 10 days or 3 days symptom-free, no cough, no fever, no shortness of breath for 3 days, that's the time you can stop your quarantine and resume your life with family and friends.
And follow up to that, do I need to be retested?
It is not recommended anymore to be retested. It was initially recommended to be tested negative for you to resume your life, but now the CDC has recommended against that, especially with that some people are carriers where the virus may live in your body for months and you will continue to test positive. But if you're not symptomatic, the risk of contagiousness is still there, but much, much lower than being infected.
So if you are symptomatic beyond 10 days, then you still isolate.
Yes, that's why we said we need 3 days of symptom-free, no fever, cough, shortness of breath. So you need the 10 days plus the 3 days being symptom-free. So the two factors together.
Okay. And what about fatigue? Patients, at least in the outpatient setting, seem to have fatigue that lasts forever. Does that qualify as a symptom to keep you home?
Great question. No, that doesn't. The fatigue is very common after viral infections, including flu and mono. You could be fatigued for weeks to come after that. You may feel lack of energy, that you don't have the stamina to get up and do things. That by itself is not a symptom that we rely on for you to resume your life and exit your quarantine. You expect to be fatigued and tired, and this varies from one person to another. Like we mentioned earlier, some people get COVID and they only get a change of taste or smell, and others can get really sick and get fatigued and tired and almost bedridden. So no, fatigue is not one of the symptoms we rely on.
Okay. And I don't know who can answer this one, but once I've had COVID, can I get it again?
Yes.
Shayla, can you elaborate on that?
Yes, because your antibodies level that are developed, it peaks, I think, I don't know the exact, but 4 to 6 weeks is, but then the antibodies does start slowing down the levels, so you're not immune forever, so it's possible that, yes, once you have COVID, after 8 to 12 weeks, when the antibodies levels are slowing down, and if you have exposure and, you still need to take precautions, so it's possible that, yes, you can get it.
So Saba, you went through a big checklist and some people are asking you can you write that down somewhere? Because a lot of it was so valuable. So that's your homework. You get us a checklist. And I can't emphasize enough, both Shayla and Saba brought this up about the advanced directives. That's one thing I think every family needs to have that conversation. So
we may need to elaborate. What does that mean? Advanced directives?
Yeah. Well, we had only a few minutes, so we didn't want to. I think Saba probably deals with it more, but Saba, do you want to talk about that or?
I think a lot of times it is a little bit more of an extensive discussion than what can be the focus of this talk. So I didn't really get into it, but I'll just briefly just mention three things. But by no means this is something on which our population needs to decide what they want to be. Full code, as Shaila just pointed out, is basically we will do everything, whatever it takes to keep you going. In other words, if you can't breathe on your own, you will be put on a breathing machine, CPR, if your heart stops beating, everything. There's another category referred to as DNR arrest CC, which is applicable only in an emergency where your heart stops beating or you can't breathe. And then I think there's a few caveats to it. Some people can choose not to be intubated, which is basically having a breathing tube put in. But in general, it basically says that if my heart stops beating and I'm not able to breathe on my own, let me go. Don't do anything. And the last category, I think that's a category we deal more in nursing homes and so on, is called DNR comfort care. A few of you might be familiar with the concept of hospice, where the family or the individual has already decided to be basically kept comfortable. These are folks that have either advanced illness or are battling an incurable disease, which is not expected to get any better. And these folks basically, just like it implies, our comfort care, we will do everything to keep them comfortable, but no major interventions. But as I pointed out, this is a discussion, at a different, maybe candid conversation. It's much more extensive than that. And I certainly don't want anybody to feel that they should decide between those three categories based on what I have just mentioned.
Okay.
Sister Shakila asked the question there. Go ahead.
Go ahead, you can answer it.
No, okay. Well, the question from Sister Shakila is what is considered obesity and how much over recommended weight you should be. It's not a in weight or in pounds how much you should be. It's as you all know, it's a calculation what we call BMI, body mass index, which is a factor of weight to height. The ideal BMI is between 18 and 24. Above 24 is considered overweight, and above 30 is considered obesity. Above 40 is considered morbid obesity, which puts you at a much higher risk of illness. And if you get ill, then it's very difficult to get out of the illness. It becomes very complicated, especially if you have comorbidities, other illnesses such as diabetes, heart disease, high blood pressure, heart failure, all that can affect the morbidity, how sick you can get.
So another question that came up, and this is for Dr. Shabir, with school starting soon, families that have elderly grandparents who have diabetes and other conditions, actually anybody can answer this, what precautions should be taken at home in terms of isolation or even contact with school-going children at home? So maybe both Asim and Sabah can share their perspectives.
I'm sorry, I didn't hear you well. Samina, can you repeat that question?
With school starting and families that have elderly grandparents who've got diabetes and other conditions, what precautions should be taken in terms of isolation or even contact with school-going children at home?
I think the schools are starting for the first time during this pandemic, and there is so much unknown right now, but definitely cases are going to rise, and you know how unpredictable children are. So I think I would take extra precaution, maybe if possible, keep the elderly patient, people in a different room, and hand washing, as I said, frequent hand washing. And if possible, maybe for if the child is showing any signs of illness, then keep the elderly away from them and wearing the mask,
Sabah, you want to add anything or?
That is actually quite a difficult question to answer. The reason is, in a household, you're breathing the same air. You're eating together. There's no way that you can be wearing masks 24 hours. As I mentioned before in my presentation, it is a calculated risk that a family has to take. So if you have really vulnerable individuals in that household, there's a calculated risk that you're going to be taking by sending school-going kids to schools. And that is not for me to define it for you. I think every individual household has to decide that on their own, knowing that in spite of all of those things, hand washing, sanitizing, if you want to do it in your homes, the bottom line is you're living in one household. So the risk of transmission is a whole different scenario than what you talk about outdoors or going out in restaurants and all of that. Having said that, one of the things that I also wanted to point out, which I didn't get a chance to, is the importance of having good ventilation. So in other words, get some fresh air every day. Open up those windows, especially, with weather not being an issue right now. Open up those windows, get some good cross ventilation so you're not breathing the same air. I've heard some of my colleagues even talking about having homes with or multi-generation households invest into a good air filter. Some of them have these HEPA filters in them that will continuously cycle and purify air periodically, just so you're recycling the air, so you're not breathing the same germs and viruses or whatnot. So those are just some practical suggestions, but like I said, it's a complicated, loaded question, honestly, to answer, because there's always going to be a risk that's going to be there if you're living in the household.
And just adding to that, just looking at this panelist, the majority of us live with elderly or are in very close contact, and it is every day a calculated risk when we go to work and come home. But
You can only try.
yeah.
Saba, you said that the good ventilation and depression, you were talking about elderly. I do suggest to my patients that I think with the nice weather, try to go to park, to grab a sandwich or something in the evening and spend some time outdoor, because with the winter coming and coldness and darkness, there will be more depression, and I think this is the time we should be doing outdoor as much as we can. Obviously, keeping the mask and all the hand washing, everything in mind,
I have a question, Dr. Malik.
Yes.
What is your take on hydroxychloroquine? With all that is going on, you've heard about everything that is going on. What is your take on it with COVID patients?
In general?
In general, yes.
So let me understand. So
I don't want to put you on the spot here, but
no, that's okay. Like when you say, what's my take, like the recovery or the?
Is it?
I think she's asking about the hydroxychloroquine.
Yes.
Oh, you're talking about, okay. Oh, we, initially, I think we had this as a part of treatment, but since nothing has been proven, actually, we, in our practice at TriHealth, that's not being offered when patients are getting admitted. So with the remdesivir being available now and plasma being offered and dexamethasone, so those three things we are offering even on patients on the floor who are needing some oxygen. Those are the three main treatments, and if there's evidence of superimposed other bacterial infection, as other physicians were saying, that you're not only coming with COVID, you can be coming with something else also, So some other antibiotics, if there is an indication like procalcitonin high or white corn, but we are not using the Plaquenil anymore.
Okay. Thank you.
So we are running out of time, and we literally have like 2 minutes left. So Asim, were you saying something?
Yeah, I agree with Saba when I mentioned that about the, taking precautions at home. I know it's a calculated risk, but if you see a child having some symptoms, and first thing which come to our mind is COVID these days. So the best thing would be to take the right precautions, like we take outdoors until the time that it is confirmed the child has COVID or not COVID, or if the child is getting, if the illness is progressing, or if it is time to take further actions, like, having the child tested. So with the elderly parents, I think we have to be extra careful. And I just am repeating myself, if the child is having any URI symptoms, cold symptoms, it will be a good idea to keep our elderly parents away until we determine what is exactly going on with the child.
Absolutely. Like I said before, every day is a calculated risk, and we need to try to do our best. So I'll ask one last question and then we'll have to wrap it up. If you have more questions, that you can send them to me and I'll try to get them to the person that can answer them. It's a quick question, Dr. Hamed. I do PCR on a routine basis and we can get it done in a few hours. Why does it take a couple days to get results when they can, what do they do in the rapid test? I think you already said the rapid test is the go ahead.
So yeah, testing is developing. It's a developing process every day. When testing came out, only few labs in the country were able to run the PCR testing, and that's why it was taken up to 14 days to get the results back. By then, we had no use for them because the patient had already quarantined and came out of quarantine. Day by day, more labs are running the test, and the turnaround time has become shorter and shorter. I personally am dealing with a lab here in Westchester, and that's why I'm able to, either one of our nurses or one of the couriers from the lab will come pick up the testing on a daily basis, the testing material, and get it resulted same day or next day. The instant testing is available in a PCR format through the Abbott testing, which is very limited. Only few centers in the United States have it, and that can be resulted in about 1 hour. So this is something that we can't talk about. I don't think it's available in the greater Cincinnati area. We have now the antigen testing, which is a machine that we have at the urgent care that will use the same swab that we do for the PCR, but it will detect the protein capsule, the covering of the virus, not the live material of the virus, and that will be resulted in 15 minutes. It's not yet approved instead of PCR, but we anticipate by the opening of the school. Now, I know a lot of hospitals have already adopted that and are using it, especially Tri-Health. And I think Children's Hospital, they're using it to test their patients before admission or before surgery. So this is a very close test to the PCR and is resulted in 15 minutes. The antibody testing is available in 15 minutes, but it is not a standard of care to use it for diagnosing cases. It's retrospective to know if you had it and you were able to fight it and develop the antibodies to it. Does that answer the question, or is there an area that needs more clarification?
I think that's all we're going to have time for today. So
Okay.
I'd like to thank Dr. Shabir, Dr. Hamed, Dr. Malik, Ms. Adewumi, and Dr. Ansari again, and all of the people who joined today and listened in. Please continue to join us, and thank you again. Jazakallah khair. Assalamu alaikum.
Jazakumullah khair. Thank you, everybody.
Thank you for
Welcome,
everyone
salam.
joining and for our panelists. We really appreciate
Thank
your
you.
time.
Thank you.
Jazakumullah khair.
Assalamu alaikum.